just a second with our Going the Extra Mile winners for the autumn. But before we get there, just a couple of comments from me. You'll see that a number of us have the new logo behind us, which is recognising the fact that last week South Warwickshire University NHS Foundation Trust was chosen to be the Acute Trust of the Year by the HSJ. So I really want to have a big shout out to my executive colleagues, senior leadership team, everyone within the organisation in the front line and behind the scenes who do so much day in, day out on behalf of our citizens. So a big round of applause from me to everyone at SWFT, a thoroughly deserved award. The second thing I would say by way of introduction is this is the last board for Simon Page and for Sue Whelan-Tracy, who have worked with us for 9 years. I'll say a few words a bit later, but Simon and Sue, thank you very much. And the third thing before we get into it is just a note of thanks and apology. First of all, apologies to our citizens who are finding when they come to our A&D that the wait times they're experiencing are far greater than anything they have previously had to endure at SWFT. We are extraordinarily busy. We are now hitting up to 380 visitors a day into our A&D, when the A&D is really only designed to see about 240 people a day. So I apologise for those of who are visiting us who are experiencing much longer delays than is normal. And that does have a consequence even on things like the car parking. The car parking we know is always a challenge, but when we're as busy as this, we do have more cars trying to park. My second is a word of thanks to everyone, particularly in the ED department, who are coping with this level of operational pressure. It is very difficult to understand unless you work in that environment, the relentless nature of the pressures and strains and looking after people in the best way possible that our colleagues in UEC endure. So enormous thanks to them for everything they do. So without further ado, we every quarter celebrate a Going the Extra Mile individual winner and then a team winner. So I'm absolutely delighted that Sandeep has joined us, who is our individual winner, Mr. Sandeep Singh, who's one of our consultant surgeons. So Sandeep, with your acceptance, I'll read out the nomination. And the nominator wrote, "We have never had such an understanding and compassionate doctor, especially when managing complex conditions like EDS, autism and anxiety. Mr. Singh truly sees the bigger picture of living with a genetic condition, focusing on patient care. He takes the time to explain everything in a way my son understands, ensuring he feels valued and at ease. In the past, my son often felt rushed and anxious during appointments, leading him to shut down and avoid communicating. With Mr. Singh, it's completely different. He creates a safe space where my son feels comfortable expressing himself, guiding the appointments at his own pace and involving us as parents only when needed. This approach has significantly reduced my son's anxieties and helped him build trust in medical professionals. Mr. Singh's compassion and understanding have been life-changing for my son and our family. He's shown that he truly understands the impact of my son's condition and has worked tirelessly to improve his quality of life. After years of feeling dismissed and misunderstood, my son now feels heard and respected. Mr. Singh's patient-centred approach, along with the incredible support from Joe and the day surgery team, has restored our faith in medical care. We are so grateful for their dedication and humanity." Sandeep, it's very rare for me to read out a nomination which I think is so heartfelt. You should feel incredibly proud Your parents should feel incredibly proud, and your family should feel incredibly proud of you. But least important of all, we're incredibly proud of you. So a big round of applause for Sandeep. Thank you very, very much for that impact on all of the patients you look after and their families. Next up then is the team winner. And our team winner is the patient experience team. Now the patient experience team, I know because of the issues they deal with on behalf of me, have a tough gig, if you'll allow me to use that vernacular. So I just want to read out their nomination, and which they received for their dedication and compassion. It reads, the patient experience team provides invaluable support to complainants, grieving relatives and the bereaved, offering comfort and reassurance during some of life's most difficult moments. Their empathy and professionalism have eased countless challenging situations, making a significant difference for patients and families. Beyond their core duties, the team has voluntarily fundraised for the refurbishment of the mortuary, demonstrating their commitment to enhancing the care environment. Their initiative has created a more dignified and comforting space, further reflecting their dedication to improving patients and family experiences. Their work embodies the trust values of compassion, safety, and inclusivity. By addressing concerns with care and diligence, they fostered trust and contributed to a safer environment. Their collective efforts have left a lasting impact, promoting a culture of compassionate, patient-centered care. What a wonderful nomination again. Big round of applause for everyone in our patient experience team. Thank you for everything you do. I know you often deal with patients and families, like the nomination said, during the most stressful and emotional of times, and the care and kindness you offer at those points is incredibly important. So thank you very much. So Sandeep, patient experience team, you're very welcome to join us for the afternoon in our board, but equally, if you've got other more exciting things to do, we'll totally understand. But thank you for all your hard work. Okay, team, so just in terms of what we've been up to this morning, we've had a busy workshop covering a number of areas on our community and integration work. We've had presentations on health inequalities from Duncan Vernon. We've had presentations on our community recovery service, which we offer. And we've also had a great presentation from our paediatric community team, who really do quite phenomenal work with patients and families in often very, very difficult situations. So thanks to them. But we will get going on with the rest of the board. Do we have any apologies for absence, Sarah?
Yes, we've got apologies from Oliver Coughley, Yasmin Becker, Nick Rees and Pramjit Gill will be joining us about 2:30.
Okay, super, thank you. Any new declarations of interest? Do you want to raise a digital hand for me, please, team? I think just for me, I'd like to declare that I'm chair of the HSJ's Trust of the Year, if I haven't already mentioned that. But on this particular minuted item, the fact that I have retired as chair of Your Cherished, which is a charity I set up and was chairman of. The minutes of the meeting held on the 2nd of October, was everyone happy with the accuracy of those minutes? If not, could you please raise a digital hand for me, please? Okay, I can't see any digital hands raised, so I'll take those as an accurate record. So I'll take us to the action points arising, which are on page 11 of the 389 in the board pack. And the first was a winter plan and vaccination plan. And this was about the 45-minute protocol. The implementation of that has been delayed, Glenn, but also there's this issue of, we were promised if that arrived, intelligence conveyancing would end, and now that's a doubt. Is that correct?
Yeah, so our position on this is we certainly welcome the implementation of the protocol, but for it to work for us, that it needs to be linked into the intelligent conveyancing stock, because if we're the only organisation in the Midlands offloading quickly, which we seem like we are at times, then we'll just receive more and more ambulances. So the discussions continue, and Harkamel will share with you later the latest statistics on demand, which including that increasing number of patients who come to Warwick from out of area.
Thank you, Glenn. We'll come back to that. And then on the capital programme quarterly update, Sophie or Jenny were going to include all the benefits that have been gained by the programme in future reporting, so we'll do that. Thank you. And then on the IPR, Fiona or Ellie, we're going to look at the outcome of the specialist palliative care services, and that's coming back to us in March 25, which, given the assisted dying legislation, is going to be an important discussion during next calendar year. And then on emergency preparedness and resilience and core, response core standards, Harkamel next year will come back to us with a further update on that. Are there any matters arising, team, that you think I've missed? Okay, thank you. So we then have the minutes of the full board meeting from the 6th of November. I really would encourage members of the public to come along to those if you get the opportunity. They're a great way of us demonstrating how we, in our rhythm of, if you like, business across the foundation group, do the comparative analysis across the 4 different parts. But for this meeting, were there any points of accuracy on the minutes you'd like me to be aware of? Can't see a digital hand raised, so I'll go to matters arising which will be considered at the next full board meeting in February, I think. So without further ado, I think we're on to, because I've done my trust remarks, on to some items for approval. And first up is the volunteer services strategy. And I know an awful lot of work's gone on this. So Ellie and hopefully Francine, over to you.
Thank you, Russell. I think Fran's not joined yet, it's a little early, but I'll start. I'm quite happy to start. So essentially, the purpose of this strategy was to support focus of the organisation on how we're going to continue to develop our already quite comprehensive volunteer services, integrate it into everything we do, and ensure that it's effectively supported and resourced and sustainable for the future. So this piece of work started earlier this year, involving stakeholders, and divisional inputs being key in this, in terms of the divisions have come up with quite a lot of asks of our volunteer service to support their services. So the request today, obviously this is for approval today. In Fran's absence, I'm happy to take any questions. Oh no, Fran's here, marvellous.
Okay, that's super. Any questions or perspectives to Ellie on the volunteer services strategy? Ollie?
I just want to share the perspective that I think this is a really wonderful piece of work. The team have worked incredibly hard on it, and it's good strategic direction, but more importantly, there's really tangible volunteering roles that have been identified that will help deliver some of our more challenging targets going forward. So yeah, I just want to commend the piece of work.
No, that's thank you, Ollie, for that. I think even on the front cover sheet with all of the photographs, it really shows the broad range of stuff that our volunteers get enthusiastically involved in, including dressing up as Father Christmas and bringing dogs in and that type of stuff. I really would encourage members of the public who are considering what to do if they take early retirement or maybe a bit of a loose end. Being a volunteer is a wonderful thing to be. Being a volunteer in the NHS is a wonderful and special thing to be. So would really encourage you to come forward. And I do know our volunteers do wonderful work. And I'm sure Harkamel will touch on it later. For example, in our A&D department, when we're very busy offering cups of tea, words of kindness and comfort to people. And equally, I know our chaplaincy and the chaplaincy support team do a lot on that as well. Any other comments on the volunteer services strategy? So are we happy to approve this? If you're not happy to approve this, could you please raise a digital hand? Okay, duly approved. Thank you very much. So we'll move on then to the performance review and assurance part of our report. And we'll start off with Glenn's update. Glenn, it's incredibly busy for ourselves, but also the NHS at this time. How are you seeing things?
Thank you, Chairman. So, yeah, there's quite a lot of work going on in the background on the long-term plan revision. Hopefully, members of the public will be aware of that, and I think I flagged it at the last meeting, the opportunity to take part in that. We've been having conversations at regional level on that also. And linked to that, there's a whole set of changes going on in the background. One of which is the single operating framework, framework through which individual trusts are assessed, and depending on the assessment that comes out of that, given relative freedoms or in some cases more control and scrutiny. We've been in segment 1 for a number of months now, and I've included within the report, I think this is a request from one of our 4 boards meetings actually, the detail of the makeup of our soft rating, but also included the trusts that are in the group, but also the other trust that's in the system with us, UHCW. And what you can see there is an assessment of a whole range of things. Quite a lot actually comes from the staff survey, and a whole range of other indicators. But it shows the highest performing quartile, which is in the blue, the interquartile position, which is in amber, and the lowest performing quartile, which is in red. And as you see, if you look down the column for SWFT, we've got 20 of those indicators in blue, we've got 9 in amber, and we haven't got any at the moment in red, and that's quite a remarkable achievement actually, so well done to the team for that. But it will change, so we haven't yet seen the new framework, but I anticipate there will be some elements of it that will relate to productivity more than they have so far. It'll also obviously be updated with another year's staff survey results by the time we get to next year. So I'll bring that back to the board when we've seen what that update is. There was talk at one point about whether there would be a closer connection between the performance of individual organisations, and as I speak, an ambulance comes in behind me, and the performance of the system in which they operate. Helpfully, I think the new Secretary of State has talked about a separation of the accountabilities of trust, but also a redefinition of the role of integrated care systems, to be more of a strategic commissioner, to focus more on the wider determinants of health as opposed to performance management. So
that'd be great, thank you.
I am looking forward to those changes being reflected in the new SOF that will be hopefully seen before the start of next year. Also, there's been insightful ICB board guidance, but also insightful board guidance, and I include a link to the detail of that for provider boards. Sarah's been looking at this also. We saw an earlier draft, and indeed some of the drafting, they took our own integrated performance report as a good practice model to bring into that guide, and particularly the elements of productivity measurement actually that were within it. So on initial inspection, we're broadly consistent with this, but we'll probably look at that in more detail. Maybe some of the audit committee would like to take a look at. And all of which takes me up to the next item. So I'm going to hold up the trophy of the Trust of the Year. I'm allowed to keep it from Harkamel and her team for a little bit longer. So very, very proud of everyone. You know, all the people on this call actually contributed to it, but more importantly, our fantastic workforce. And we saw a couple of great examples, both a team and an individual earlier. And the trust is bursting full of people like that, and it's really great to recognise that. So this is one for all of the staff, and it's also been reassuring actually to see a number of other indicators over the last few weeks. So we saw the National Inpatient Survey, we've seen a recent A&E survey, patient survey, we've seen maternity survey also, all of which we're getting really good feedback from service users that our teams are delivering great care. So despite the pressures, and I won't steal any of Harkamal's stats because she's always full of stats, but these are the busiest days that we've ever seen, and yet still we continue to get really good feedback from our patients. I do worry about that actually, and one of the things we'll probably look at later is the amount of urgent care demand that is coming to Warwick in particular from people who are choosing to come to Warwick from out of area. And whilst I would always be keen for any patient to be treated as quickly as possible, it isn't always the best thing for those patients to be seen in an A&E that's not within their locality. It can be harder for us to discharge those patients, and it can be harder for us to know some of the other support arrangements that are in place. So I would encourage those people who use us from outside. It's great that you recognise the great care that we have here, but really would appreciate people going to their local A&E and hopefully getting a great service from that also. Then there's an extract from the quarterly system review meeting. I then talk about dermatology as a specialty. Recently, our dermatology team moved into our new facility, the Warwick Dermatology Centre, which is a GP practice, which is just down the road from Warwick Hospital. It's a fantastic place for dermatology. The team were really excited to show me around a few weeks ago, and well done to the project team to make that happen. And it's increased our capacity in what is an ever increasing specialty for demand. And I was quite struck by the statistic there. 24% of the population consults a GP each year because of a skin complaint. And it just shows you the kind of volumes that are coming through that service. And despite a really tricky recruitment scenario, and we're certainly experiencing this elsewhere in the group, we managed to have 100% consultant retention. We're developing specialty doctor grade, and we're managing to cope with an ever-increasing demand, some of which actually is being delivered through nurse-led cancer clinical nurse specialist clinics. So well done to that team. And then the remainder of my report includes a citation for individual and team winners for the Going the Extra Mile Awards. So I'm happy to take any questions.
No, thank you, Glenn. And the Ned spent time with Glenn this morning, as we do once a month, getting briefed on everything Glenn's just talked to us about. But any questions or perspectives to Glenn? Glenn, I think it is probably worth, just with so many members of the public on board, just to give a perspective on the very, very tough financial outlook we think is heading our way for next year, just to manage expectations.
Yeah, by the time we meet again as a board, the annual planning guidance will have been published. The planning guidance sets out the framework in which we operate from April next year through the end of March following year. And that will put in context obviously we've had a recent budget from the new government, and whilst the headline indicates the NHS will have a real term increase in funding, that funding 2.5% looks like it will be more than taken up by inflationary impacts, including pay awards. Obviously we are protected from the national insurance increase, but lots of our supply chain are not. Primary care is not. Some of our social care providers will not be either. So what we are looking at is potentially, well, almost certainly a reduction in funding next year, despite what we'll also see as another further demand. And the A&E increases have been quite dramatic. So balancing those two next year will be really difficult. And then alongside all of that, the year that we're in, and you'll hear from Kim later as to where we are with that, many trusts across the NHS, many systems across the NHS are in large deficit positions, which will go into next year and will take even more money away from the NHS. So it's a worrying scenario, and we will, as ever, plan our way through that in a way that ensures that we get the balance right between the productivity, efficiency, and the quality of the service.
No, thank you, Glenn. But again, we are looking at real transformational challenges and opportunities as we look ahead over the next couple of years. Okay, if there are no questions to Glenn, we'll move on then to the integrated performance report. I'd just like to thank Sophie Gilks for continuing to hold the fort whilst Adam is unwell. Adam, if you're watching this digitally, we wish you a speedy recovery and look forward to you coming back as soon as possible. But in the meantime, Sophie's doing a great job. And so, Sophie, do you want to introduce the IPR for us, please?
Thank you. So I think we'll see a theme going through as colleagues talk about each of their areas, which is a big thanks to everyone, because the demand we're seeing, and it's reference, I've pulled it out around emergency, but the demand we're seeing in all areas at the moment is incredible. And so the response from our teams is actually, it is something to feel really proud about. People really care and are doing everything they can to manage that in the wake of that demand hitting them on a day-on-day basis. In terms of the 3 areas of concern to pull out, 2 of them have already been mentioned, so our increase in urgent care demand and also our in-year financial position and the challenge going into next year. And both Harkman and Kim will pick them up, like Glenn said. The other one is around the turnaround times from the Coventry and Warwickshire Pathology Network. We are looking to strengthen our governance in that area to have more impact on making improvements in that space. But again, I think Harkman might touch on that in her report. And then to end on a positive, we're seeing some really great work in HR around our recruitment metrics. And just to throw another award in, because it feels like that sort of board, it's really great to let you all know that our team won the best recruitment experience from the Nursing Times Award. So it's real testament to that focus we've had as an organisation on recruiting well and then retaining, which is going to be essential moving into the next financial year. So with that, I'll hand over to colleagues.
Okay, thanks. Just before you do, just a couple of brief points is, particularly as you mentioned, the recruitment work. Elva has been on maternity leave. We're looking forward to welcoming Elva back. And Nick, who's been stepping in for her on an interim basis, is unwell today, hence Sarah's kindly standing in. But Nick, I'd just like to publicly thank you for the work you've been doing over the last number of months whilst Elva's been on maternity leave. I think we've also had a number of our patient experience team join us just in the last few minutes. Guys, we've congratulated, celebrated and shouted out in thanks to you earlier on our Going the Extra Mile team winner. But in case you missed it, I'll just say again, thank you for everything you do. It was a lovely nomination. So with that, we'll go to Bhaskar and Ellie on quality and safety. Bhaskar and Ellie, what would you care to pull out?
Thank you.
Well, as you will go on, Ellie.
Shall I go? So we've just put a highlight into our falls improvement work. So that's been going on for some years. It's been a journey and it's really pleasing to see the falls with harms have come down. There's no one attributable measure to that, which is why there's a lot listed in there, but it has been a concerted effort by everybody. All the frontline staff, the patients themselves have been involved, as well as our falls lead to get us to this point. So that's pleasing. And then just wanted to reflect that we had a high number of formal complaints in October. However, what I've asked for future is that our complaints are put per 1,000 bed days or per contacts as other measures are, because obviously our activity in October was huge. And so what I don't want is for any department or service to get discouraged feeling they're getting more complaints when actually they're seeing more people. And those are the two key things. Thanks,
Sally. Bhaskar, anything you'd like to add?
No, I just wanted to highlight the fact that the falls rate steeply coming down in the context of unrelenting increase in throughput and complexity is just phenomenal reflection of the quality that is going beneath it.
No, thank you, Bhaskar. And I'd just like to have a shout out on falls to David G, who's one of our governors who over many, many years has been a real advocate of the falls prevention strategy and work. Any questions or perspectives to Ellie and Bhaskar? Okay, team. And so we'll move on then to Harkamel, who drives the engine room, if you like, of the trust and the hospital. Harkamel, things are very busy. Can I ask everyone to come to mute? I'm getting lots of feedback. So Harkamel, over to you.
Thank you. So as has been said, October was a very busy month for SWFT. We had our busiest month ever in A&E with our highest level of attendances. We also carried out our most operations from an inpatient perspective in October and delivered a lot of babies, a lot more than we did the previous month. So overall, a very busy time for October. When I come back next time, I'm going to tell you that we were busier in November than we were in October. But we are where we are for the purposes of this report. During this time, I just want to echo what has been said already. Our teams have worked tirelessly to keep our patients safe and to carry on delivering excellent patient care, and with a real focus on patient experience. If you go down to ED and patients have been there much longer than we would want them to be there, they will be on beds. We work really hard to make sure that they have pillows. We've made sure that the menu is nice downstairs. And although it's not a place that we want patients to wait in for a long time, we know that we are under a significant amount of pressure. And I just want to thank the teams for maintaining safety, but also really keeping a close eye on that experience overall for patients. It's been mentioned already about volunteers and about patients who come to us from out of area. And I just wanted to extend my thanks. We do get a number of patients who travel in an ambulance for a really long time. I think an hour is a really long time when you're perhaps older, more frail, and more poorly. And often those patients will come here without the visitor and will spend quite a lot of time potentially on their own. And the volunteering team have been fabulous in terms of making sure that that our patients don't have that negative experience there. They really do parachute in and sit with our patients. So just as I tell you how busy we are, I just want to thank the wider teams for absolutely everything that they're doing. I've alluded to it already in terms of how busy we are and things aren't where we want to be, but I am still really proud of our ambulance offload times. In October, we were still one of the best in the region in terms of offloading our patients as quickly as we can. And although we did have some patients who waited over 12 hours, the numbers were small comparatively, so it made up just about 3.4% of our overall attendances to A&E. The out-of-hospital division were key to supporting the trust in terms of flow. We've seen great response rates and improvements in length of stay, which has been key to getting us out of some of these really precarious positions. So I just wanted to extend my thanks to them. I've included a deep dive slide on cancer, and this is because we know that performance is not where we would like it to be, and that is a national picture. Many of these targets have not been met nationally for a really long time. And I've presented some information before, but I just wanted to reassure the board that our focus has not been taken away for cancer with everything else that we've got going on. Referrals remain high, so specialties like breast and head and neck see a significant amount of referrals. And the position, I've got to be honest, is fragile. Any variation really does impact on our ability to deliver cancer. So some of those really significant peaks that we see in demand, because we're trying to get to people so quickly, it can become really challenging. Any sort of equipment failures and things like that pose real problems for us. And we do rely on partners to provide some of our more specialist diagnostics, provide pathology, and to provide us with timely access to oncology. And I've mentioned before that we struggled with that, and whilst waiting times have improved, it is still an area of focus and certainly something that we're not taking our eye off the ball with. I wanted to point out as well that our governance is much more robust than it ever used to be. The way that we do work with our partners is a lot more established now, and we are continuing to work on streamlining both internal and external processes, which feels quite important. And we are seeing some really strong green shoots. So the colorectal team have absolutely revamped the way that they work, their entire rota really, to provide some much needed capacity. And I think that just demonstrates how committed everybody is to improving our cancer position and making sacrifices that means that fundamentally teams are changing the way that they work. And I am very grateful to everyone who is involved in improving our cancer waiting time.
Thank you, Harkamel, for a very comprehensive summary and for the enormous hard work that you put in. I'd just like to say again, because members of the public may not be aware, that, can you go on to mute, Harkamel? I think it's your machine and mine. When we're very busy, a member of the executive is on call overnight. on a regular basis. They don't get any time in lieu, but they have to be there to respond to any urgent requests or calls from, for example, West Midlands Ambulance Service. It means that our executives are quite often woken up in the middle of the night to address an urgent issue. So I'd just like to thank everyone who goes on call overnight, because it isn't an easy gig, and I'm very aware of that. So questions and perspectives to Harkamel. Robert?
I was just going to ask Harkamel, just in terms of that increased activity into our ED, is that sort of evenly spread across patients arriving by ambulance or people that are coming in through minor injuries?
It's not minor injuries, it's actually our type 1 activity. So
yeah, sorry, that's what I should have said. If
you compare 2019 with where we are now, so the April to October 2019, we've actually seen an 11% decrease in ambulance arrival, but we have seen a 49.7% increase in walk-in activity of the type 1 activity only. And type 1 are those patients who are the most poorly true A&E patients. So the walk-in is driving this. It's just that the complexity that we see of patients when they're brought in by ambulance, especially when they're out of area, has a disproportionate effect on how we manage flow.
Glenn?
I mean, just to add to that, if you look at the year-on-year activity changes from 22.3 to 23.4, Warwick residents, Warwick postcodes were 8.3% up, Stratford postcodes were 3.5% up, but we saw 21.8% from Coventry postcodes and a 51.6% increase from Rugby postcodes year on year. So some of this is that disproportionate out of area activity, which as I said earlier, often it is harder for us to discharge those patients if they need to be admitted because of the pathways being different from those that we use locally.
No, absolutely, Glenn. Thank you. Any other questions or perspectives? Harker, I think it would be good with, for example, pathology services. Glenn and I, in our George Eliot board yesterday, suggested that we might want to take patient stories to the pathology service so they realise the consequences of the delays on families and patients, particularly when it comes to histo and patients waiting for a cancer diagnosis. We know it's an extremely worrying time. So if you could maybe think about some patient stories with colleagues, which we could feed into the pathology service, because I worry that these sort of third parties that we rely on often just work in glorious isolation and don't have to cope with patients and families in the way we do. So they need to share the consequences of a failure to deliver to their service level agreements. If I can ask you to think about that. Colleagues, happy to move on? We're in such a busy period. Health and well-being for our staff is very important, as is the recruitment of high quality staff. So Sarah, what would you like to put out Nick's report?
Thank you. So as Sophie said, our recruitment is continuing really well. We were absolutely delighted to win the Nursing Times Award. We have seen a reduction in our vacancies and also in our time to hire. And both of those then also have a positive impact on reducing our temporary staffing usage, which improves our patient care experience. Our turnover has also reduced. So not only are we able to attract people to the organisation, but we're also then retaining them, which is fantastic. Sickness absence remains our primary area of concern, and there is a deep dive slide in the report. Although out of hospital has the highest absence rates and is therefore quite a focus of attention, we have seen an increase across the whole organisation, and that is specifically in short-term sickness. So that's our area of focus. We've developed a revised sickness management policy, which has got much clearer guidance in it. And we've developed that in collaboration with our staff side reps. So that will go through JNCC for approval. And I think finally, I would just like to say a huge thank you to everybody who's completed the staff survey. So we don't have the final response rate yet, but we know that we exceeded last year's response rate of 51%. And so it's really important that we hear staff voices, that we understand how people feel, and I really hope that we continue to build on the positive views from previous years' staff surveys. Thank you.
Thank you. So any questions or perspectives on our people side of our operation? Ollie?
Yeah, just a quick question. What, if anything, are we doing to proactively recruit veterans into SWFT at the moment?
Okay, so yeah, we have we're part of the Veterans Alliance, and therefore we do proactively work with local veterans organisations, both from an employment perspective, but also from a patient perspective. So I'm happy to pick that up with you outside, Ollie, to go through kind of all the work that we're doing with veterans.
Yeah, I think it's a great question, Ollie. I think we've, certainly down at Wye Valley, we do a lot of work with veteran associations, but I think there's more we can do, even if it's on the volunteering side, let alone on the employment side. Any other questions to Sarah? Okie dokie. So we'll move on then to the money, which is very, very difficult this year, Kim. I know we often say it at this time of year, the most difficult year we've been in. But over to you.
Thank you, Chair. So I think what we see in the finances is really a reflection of what we're feeling within the organisation. So this is the month at 7 positions, so that's October, and just like half a mile, I think the November position that we're feeling now, is probably is going to be is not feeling great. At the moment. So we're reporting a £4.5 million deficit against £1.7 million deficit in terms of the year-to-date position. Now that is an adverse variance from last month. The significant movement is about £1.8 million of pay award that shortfall from funding that we've received from the National Centre. Now, we think that risk is around 3 million at the time of writing this report, but we've been working with their team, and we think that figure is probably closer to about £1.5 million now in terms of a full year impact. So that does give us a problem at the moment, which we're not sure how we're being asked to address that. So there's obviously national conversations going on at the moment. So if you park that as a risk at the moment that we're still working through in terms of our full year impact, then at the time of writing, I still thought that we would still be trying to get to our full year plan, which is a £1.3 million surplus. But having obviously gone through another month, I think we're at the place where we're saying we probably can't get to that surplus plan. Our statutory duty, just to remind members of the public and the board, is to deliver a break-even position. And we are obviously working together to endeavour and do our best to do that. But I think it's fair to say at this point in time, I'm suggesting that we're moving our forecast really from a 1.3 million surplus to a break-even position. Even that is with risks, and I'm sure we'll have further discussion at confidential board around risks and mitigations and where we think we potentially could outturn. Now, Glenn mentioned, I think earlier, around the additional activity that we're seeing out of area, and have we been in a different kind of financial regime and being paid tariff for that urgent care activity, then we would actually see a very different picture. So if we were being paid for that, then we would potentially get an additional sort of £3 million for those patients that have been admitted to our trust, but also a further £1 million for the ED attendances that we're seeing as well. So that I think is really important picture to present, because clearly we're incurring cost to actually look after the patients and make sure that they're safe. And by opening additional capacity, which we're not funded for, we're not built for, and that's obviously a real challenge for us. And we're feeling that pressure, and we're seeing that in terms of the financial position. So I thought it was really important really to highlight those issues. We've got some gaps in terms of our cost improvement plan. We had a really challenging cost improvement plan at the beginning of the year of £20 million. We've identified about just over £18 million. So we've got a bit of a gap to find, but we equally got to make sure that we deliver the target at the end of the year. But obviously, it's the operational team that are delivering this or expecting to deliver this, and clearly they're managing the operational pressures that we're coping with at the moment. So it is a risk really to our position. Clearly, as an organisation, we work well together, and we will continue to try our best to ensure that we deliver our statutory duty. But I do want to give the board heads up that it's a real challenge for this year. Glenn's already alluded to the next year position as well. Again, we're expecting the guidance to come out Christmas. It always seems to come out just before Christmas Eve or something like that. But again, the planning round this year was really late. We're hoping that we're not in that place this time round. But clearly, we're already starting to work around what does next year look like, and some of the challenging decisions that we may have to put ourselves in order to make. Cash is the challenge for us as well. Given the deficit position that we're in at the moment, we have made an application for PTC revenue support, which is like a working capital and overdraft layman's terms to help us out. Although at the moment we're managing our cash position well, but it is a challenge for us moving forward. So I just wanted to, again, bring that to the board's attention. But otherwise, I'm happy to take questions.
Thank you, Kim. So we should brace ourselves for break even at best. Questions and perspectives, Glenn?
Yeah, it's obviously disappointing that we're in the position that we may not be able to deliver the planned surplus. Or colleagues will recall that surplus was to offset deficits elsewhere in the system, but it looks like elsewhere in the system the deficits are higher. So the system overall is likely to be in deficit, and that could mean higher levels of scrutiny, which we're not uncomfortable with higher levels of scrutiny. It's just the time associated with it often that is the issue. As Kim said, though, I think one of the things that we really do need to sort out as an NHS is this separation between organisations that are doing too much activity versus those that haven't got the appropriate levels of productivity. And at the moment, most acute providers, I think with possibly still the only one that isn't getting support, are in deficit. And you can't tell from the outside looking in whether that deficit is a productivity problem or a demand problem. So I, for one, certainly hope that we move to a situation where there is a wider tariff. It works with elective care. It should work with urgent care, but it's just a way of separating out those two very, very different issues. One that needs system support and one that needs organisations to focus on the costs of delivery. So I hope that comes through, including maternity services. I see no reason why that shouldn't be a full tariff model. So let's see what transpires.
Thank you, Glenn. And Robert?
The paper alludes to, an encouraging trend when looking last year at the costs of agency. Can we be assured that we're doing everything we can to continue to bear down on expensive agency costs?
Yeah, so we've made a significant, inroads in agency, particularly around nursing agency. And thank you, Ellie, for your leadership on that. I think in terms of our medical staff, I think there are still some opportunities indeed. Nick and the executive team are actually looking at that in further detail tomorrow, our exec day, in terms of what else we can do. We've got, we've moved to our medical agency reduction board on a 2-weekly cycle now, which is led by Jack Foster and Bhaskar. And we're thinking and planning more proactively around making the right decisions moving forward in order to minimise risk of gaps and therefore the need for short-term agency at premium costs. So Bhaskar and Ellie, I don't know if you want to come in and join the conversation.
Yeah, sure. I think, yeah, we're certainly putting the zoom light on the medical agency, and the challenge, of course, is national shortage in some specialties that continues to justify for the sake of quality and performance to some extent. But it's something that we're actively doing and hoping to exploit even more as the foundation group footprint gives us a little more flex with use of precious resources across borders. So it's something we're definitely working hard on, and will continue to nibble away.
Thanks, Bhaskar and Ellie.
Yeah, just to echo that, really, we're continuing to work to drive down agency rates and reduce temporary staffing for quality as well as for financial reasons, because it provides much better continuity of care and well-being in our teams.
Great. Any other questions to Kim? I'd just like to segue back to something that I was expecting Harkamel to mention, but she didn't. We have today 68 patients who are medically fit for discharge, and about 40 of them are waiting for a care package. Just to put into context the cost of that, on the basis that every patient who stays with us is about £400 a night. It's a bit less than that, but it's about 400. Times by 365, that gives a cost to us of keeping those patients in our beds of 5.9 million a year. So Kim indicated we could be roughly 4 million better off if we were given the income we would previously have expected for our A&D and other work. But we'd be 5.9 million better off if we didn't have these medically fit for discharge patients. Why have we got these patients in our care? Because they're in the wrong setting. They should be at home with a care package. If we assume that it costs £200 a night to look after someone in a care setting, to be honest, it's close to 50 quid a night, then the system could save just under £3 million. But that's not happening because the NHS is funded differently from social care. And so one of the real things we hope for is that the 10-year plan addresses the underfunding in social care, which leads to people spending too long in the most expensive healthcare setting, which is the acute hospital. And so there is an enormous amount of taxpayers' money that could be saved if social care was sorted. And one of the big risks for us next year, for members of the public who are on the call, because my board colleagues have heard me talk about this, is the increase that Glenn referred to in national insurance and the reduction in the starting levels of national insurance, which now covers a lot of part-time staff, is financially catastrophic to care homes, to hospices, to charities, and to domiciliary care providers. And so unless this is addressed by next April, we are liable to see a significant increase in medically fit for discharge patients being stuck in our hospital beds, which is an economic nonsense. So moving on, Kim, we look forward to the confidential board discussion, but I think we're quite clearly indicating that we would be happy with break even this year, given the very strong headwinds that you've outlined. We'll move on then to the Learning from Deaths trust-wide update, which is on page 80 of our pack. Bhaskar, anything you'd like to pull out of this?
Well, I just wanted to highlight that we're doing our mortality figures are steady and within controls for several months now. And in fact, the better figure of the shimmy is in page 192 of the 397 pack, because even I didn't quite understand the 82nd page figures. And the RAMI figures, which are even more referred to with risk adjustments, showing a nice downward trend to match the peer levels. So I think we're doing well on the controls. we have a well-embedded ME system, and now recently embarked on a new incident reporting in-phase system within which we have a mortality module, which I'm led to believe will give us even more intelligence on learning from death, because it captures those SARs into themes and pools that we will have more to learn from. So I think the overall headline is our figures are holding fine, and there are some flags raised on the RAMI with pneumonia, sepsis, and AKI, all of which have been through further deep dives, and the Mortality Surveillance Committee is keeping a very close eye and reporting to the CG3 quite regularly. I'll take questions. Thank you, Chair.
Thank you, Bhaskar. Any questions on the learning from deaths report from Bhaskar? Okay, thank you, and thank you for the Equality and Safety Committee for the work they do, sort of working with you, Bhaskar. We'll move on then to the quarterly safe staffing report. Ellie, what would you like to pull out?
Thank you. So it's quite pleasing to see that some of our staffing risks have been closed in the last quarter, and that's down to some of the recruitment and retention work that Sarah referenced earlier. It should be highlighted that we have seen an increase in incidents related to staffing in this quarter, and a lot of that is reflective of the increased activity, the fact we've had additional beds open, we've needed to staff spaces at short notice, and also because of the sickness, which again Sarah highlighted in her report, which remains slightly high for nursing. However, we are working very closely with our people and workforce colleagues to try and support people back to work as quickly as possible. And those are the key things I wanted to pull out.
Thank you, Ellie. Any questions or perspectives on the safe staffing report? Okay, very clear. Thank you very much, Ellie. So we'll move on then to the perinatal quarterly report. Lorraine, welcome. As Harkimo indicated, things are very busy with lovely babies arriving just before Christmas. Over to you.
Thank you, Chair. So yes, this is quarter two's report. I'm just going to take the highlights from that report. As we've discussed, we know that maternity continues to have a high birth rate. We've done a lot of deep dives into our data to understand that. We know that's been driven by some of our out of area work, and we are working with the Trust to look at a 3-year maternity neonatal strategy about how we are going to progress and manage the increase in the birth rate that we have. We know, just looking forward, as we've said, October was our biggest birth month, but that continues. So thank you to the staff who've done an amazing job to keep our mums and babies safe. Obviously, we know that our theatre capacity is also affected by that, so that remains one of our risks, around one from environment, but two around the increased elective section work that we've got going on, and we're working really closely with the elective division around theatres to look at how we manage that and progress the work that needs to be done in that environment. We've also been working with our colleagues in Innovate to look at what the impact may be if we go on to Cerner, and that work is ongoing. In quarter two, we had 2 cases that met the perinatal mortality review. Obviously, we've given support to the parents and mothers and babies that have been involved in all of those reviews, and also to the staff that have been involved. And obviously, our hearts go out to those families that have had suffered any loss. But it's just reassuring to see that our perinatal mortality rates remain way below the national average for stillbirth and neonatal death. Really pleasing to see our Saving Babies Life compliance has now hit 96%, and we're now complying with 4 out of 6 elements. And I do say all the time that last bit of percentage that we need to get to full compliance will take a bit of extra work, because some of that is outside of our ability to achieve. That's more national. We've also been working really hard to achieve our CNST compliance. I'll be coming to Confidential Board to update on that, but the cut-off for our compliance was the end of November, and the team have worked really hard to try and achieve that. Really pleasing to see our vacancy rate is 0 for midwifery staffing. Really pleasing that people want to come and work here, and we're doing really well with our retention. Obviously, as we've discussed, we've also got increased sickness rates there that we're working really hard with HR to reduce. So those are the main highlights I wanted to bring from the report, Chair, but happy to take any questions.
Thank you very much, Lorraine. Any questions or perspectives, Lorraine? Lorraine, sorry, I didn't ask you this in advance, and so I don't expect you to have the number, but if you do, that's brilliant. But I have the number locked in my brain from one of the other bits of the foundation group, hence the question. What is our birth rate plus calculated whole time equivalents compared to our actual whole time equivalents?
So yes, we did ours back in April, and we did take a paper to board. So we found that we'd got a deficit of 8 whole-time equivalent midwives from what birth rate plus when they all felt we needed to what we'd got it. But actually, because of the increased capacity, we have been funded for those additional midwifery posts. So we've taken those on additional and recruited them, hence why we've got a 0% vacancy. So quite close to that, but actually it did show that the drive in acuity and capacity did require more staffing, and we've been funded for that. Thank you.
So thank you. So at its simplest, I know it was done back in April, but when we did the calculation back in April, it said we were short of 8 midwives, but we've since recruited to those 8 midwives.
We have indeed.
Thank you. And Glenn?
Yeah, and thereby lands a tail. I quite rightly, we've got methodology here, but I do worry about some of the methodology, and I'll be consistent because I say this in other boards that I think there are other factors at play here, including ward layouts, the skills and experience of the individual midwives. So I don't think it's as precise as that, but there is an awful lot of pressure on maternity services across the NHS to implement the numbers that come out of that tool. And as you've already heard today, despite an increasing number of births, we're in a fixed block contract for maternity services. So it's no wonder that we find ourselves getting into financial difficulty when you've got input measures that tell you need more and no extra income. Something has to give.
Yeah, absolutely. And we did escalate to NHS England and the ICB around the additional funding that we've had to put into to maintain that capacity. So that work is ongoing across the system to try and even out the birth rate across our system, because actually it's not quite as equal. For example, George Eliot's birth rate has gone down, acuity has gone up, but actually ours is acuity and capacity has gone up. So it's about evening it out through the system too.
No, but your point's well made, Glenn. Thank you. Okay, Lorraine, thank you. Please thank the team. If I don't see them before, wish them a happy Christmas. So we'll move on then to the patient experience quarterly report. And we are back with you, Ellie.
Thank you. So just to pull out a couple of bits, obviously our patient experience team got their jam today, which is amazing. And just to highlight that they don't just deal with complaints, they are our bereavement service. They do a lot of engagement work. They manage our friends and family feedback test, the translator service. There's a lot that are going on. So I'll take it mainly as read. We've already talked about the formal complaints. And it's good to see that our PALS team are actually going out to Leamington and Stratford now as well. So the perception is just the Warwick service isn't correct. They will go out wherever they're required. So apart from that, I'm happy to take any questions.
That's great. Thank you, Ellie. Any questions or perspectives to Ellie on the patient experience report? Worthwhile remembering in terms of our inpatient experience, we ranked amongst the top 3 in the whole of the country. So very well done, team. The Improvement Board quarterly report, Glenn.
Yeah, thank you. I won't.
Sorry, someone had their hand up and I missed that. Apologies. Did someone want to ask Ellie a question?
I think it was Pramjit coming in from the lobby, Russell.
Okay, thank you. So Glenn, back with you.
Thank you. So I won't read through the report. Just one thing I wanted to say about it. So the Improvement Board looks at how we manage improvement across the organisation, looks at some examples of some of the work that our improvement teams and the divisions are doing, but then also review some of our business cases. And I think, I mean, one of the things that the judges in the HSJ Awards picked out was the improvement mindset of the organisation. We use the CUSA methodology, which is an NHS branded improvement methodology. Actually, incredibly good value because it's funded by the NHS, and I just wanted to pay credit to firstly Aqua who manage that on behalf of the NHS, but also our improvement team who are fantastic, and their main role is to make improvement everyone's business, and through training and support they absolutely do that, and that's one of the reasons why we managed to keep doing so well despite all the pressures that we're under. So thank you for the team for doing that, and thank you for Aqua for supporting the QSIP programme.
Thank you, Glenn. Any questions or perspectives for Glenn on the improvement programme? Absolutely part of the foundation of making us the Trust of the Year. Sue Whelan-Tracy?
Yes, I wanted to ask two questions. One, it's not in the report, but is there still an improvement project or programme running for pharmacy? Because I see throughout today's papers references to challenges within pharmacies. I just wanted to double check whether there's still an improvement project on pharmacy. And then secondly, I noted that the recruitment and retention staff support business case review is standing down the posts for psychological support for staff. And I just wanted to say that I also read in the papers around the occupational health service being looked at again, and really welcome that we're being dynamic in making sure that the offers that we've got match what staff need. And I wouldn't like to think that stigma attached to requiring psychological support was something that we just let sit there. So we need to recognise that we need to try and remove these stigmas. Thank you.
So Glenn on the first, then Sarah on the second.
Yeah, I mean, Jenny might be able to help me. I mean, in terms of improvement projects going on all across the organisation, and part of this is the QSA training tiers that we have. So there's basic level training, intermediate training, and specialist training, and then there's some overall change programs, which we may touch on in a moment, actually, when we talk about Excel in Everything. And I think there's some elements of that are touching on pharmacy. So there is a lot of change going on. Harkamel's about to tell us about something specific in that field, I can tell from the smile on her face. So Harkamel, do you want to come in and help me with that one?
Harkamel's frozen. Harkamel, are you there? Oh, we were expecting something.
Yeah,
Sophie.
I'll come in because Harkamel gave me the answer, which is yes, that programme is still happening and it's feeding through to our management board in terms of the pharmacy one.
Okay, great. And then in terms of the development of our health and wellbeing service, Sarah?
Yeah, so absolutely, staff psychological support is part of that review into our occupational health and wellbeing. So it's very definitely incorporated into that review.
Okay, great. And we're certainly ensuring that if any members of staff do require psychological support, there's never a suggestion of stigma. All of us go through tough times and we all need a helping hand on occasion. So if you're going through a tough time, just reach out and ask for help. We're here to help. Happy to move on, team. So segues quite nicely the improvement work into the Excel at Everything programme. Sophie?
So just a couple of things to pick up. One is an assurance piece for the board following the transfer of some of our services into the company. I think Kim in particular has identified the need then for a SWFT Clinical Services Excel and Everything programme. So we will make sure we don't lose any of those improvement pieces of work that we were doing through the transfer of those services. The second thing to pull out is really great progress around the medical and nursing agency reduction through this programme, and Ellie and Pascal and others and Nick on the call in terms of that work that has shown real improvements. And then finally, we're doing work that Jen Nichols is leading around. We've had an internal audit review of the programme. We're going out to members of the programme so that we can really prep and think about what we're putting in place for next year. So we don't just do the same, we improve our approach to this as a programme of work. So Jen Nichols is leading that work.
Thank you for the summary. Sophie, any questions or perspectives to Sophie? Okay, keep pushing, Sophie, on that programme. Jenny, thank you for everything you do as well. We'll move on then to medical revalidation report. Pascal, what would you like to put out of this?
Thank you, Chair. I take the papers being read. I can assure that there has been a smooth transition from Charles to myself in terms of the RO responsibility and the GMC Connect. And as you will have seen from the report, we're continuing to comply very well to the requirements with an ably supported team that is overseeing this. And we've also, there's one more thing. The one action that we didn't quite comply, which was the peer review of our appraisal. We're now embarking on that, and our colleague from Y Valley is going to oversee that bit so that we tick off that one standard we haven't quite complied last year. Happy to take any questions. Thank you.
Thank you, Pascal. Any questions or perspectives, Pascal, on the revalidation work? Okay, duly noted. Thank you. So we'll move on then, and it's you again, Pascal, on the trust performance against national guidelines on learning from death.
Yeah, like I've already covered before, I think our figures are holding fine and we are well within controls with some downward trend from our previous peak. And we're continuing to have robust mechanisms put in place to get some learnings and clues early and put in some remedial measures. And, well embedded MSc, the mortality surveillance and the clinical governance continue to support this piece of work. And our recent uptake of in-phase for our incident reporting gives us that mortality module within it, which I'm genuinely keen to see what enabler it will give us for intelligence. Thank you.
Super. I always like a report which has a section on what worries you and why. Any questions to Pascal on the 6 monthly update? So we'll move on then. Sue, lovely to see you. We saw DP yesterday on the Freedom to Speak Up update. How are you seeing things, Sue?
Yeah, not too bad. We're hot off the press of a ward round last night, so we spent some time at Warwick Hospital visiting our ward staff, so that was quite interesting. Some themes that I've sent to Ellie already, so you'll look forward to that, Ellie, when you get a chance to read your emails. Some of the themes are reflective of what you've already said in board, so we're recognising a busy position, lots of patient movements, lots of pressure on staff, so some issues around staffing levels, acuity, as we always see when we go and visit teams, especially at night time. Lots of patients that need that additional care, so the one-to-one support, the extra pair of eyes on them because they're falls risk or they need special. So that was definitely reflected last night. Some concerns that are coming in that are fairly new around rebandings and agenda for change. You can see in the chart at the end, thematic every time, every quarter around recruitment and agenda for change is often something that comes up, but time it's taking for rebandings is something that we've seen that staff are complaining about this quarter. Other things, the well-being impact on staff is still quite significant, and it's all that moral injury stuff again, so still staff feeling that they can't do the job that they really want to do, they can't give the care that they want to give to patients. So that's definitely reflected when you get out and about and you see staff face to face. Those concerns don't always come in as a concern, but definitely when you're out and about and you're talking to staff, that's the conversation that's reflected to us. And we could definitely see that last night on our walk around. You could see how busy it was and how under pressure staff are. So I wouldn't be surprised if we don't get a little flurry of concerns, because that's usually what happens when we've been out and about. And as you can see from the report, still those concerns about behaviours and attitudes. And again, when staff are busy, when they're under pressure, when they're tired, those behaviours do sometimes escalate and we get the snipiness between staff. So that's definitely reflective. But we're continuing to work really hard on the civility programme. We're continuing to work with organisational development, HR colleagues, trade unions to go out and speak to staff. And the other thing that's thematic is the work we're doing with Ola and the EDI team. So we're definitely seeing an increase in the number of concerns coming through from a protected characteristic background. Significant ones around race and ethnicity. And we are seeing an upward trend in verbal abuse and discrimination with Asian colleagues versus Black colleagues and Asian versus Asian colleagues. And I think we're seeing that just because we have the mechanism for staff to report, and they are using the anti-discrimination help desk. They are engaging in the listening events that we're doing. So it's probably not that these are new things. We're just talking about them and hearing them, which is brilliant. So other than that, I'll take the report as read and happy to answer questions.
Thank you, Sue. Any questions or perspectives to Sue? Sue.
Thanks for the report, Sue. I just wanted to note first off that it's really interesting and pleasing that all the referrals into Freedom to Speak Up have been named, that they've not been anonymised, and I think that speaks to culture that you and your team and everybody is role modelling. I think I spent some time with the anti-discrimination help desk. I thought it was a really pragmatic solution to staff feeling sometimes that change doesn't happen. I heard that it will be formally evaluated at some point. I think it would be really good to bring that through to board. And yeah, just wanted to say it was a really skillful approach that I saw in action there. So just to commend that work.
Thank you. Yeah, we're planning a 6-month review because that will be coming up soon, and then we'll do a 12-month review as well for the discrimination help desk.
Thank you, Sue. And any other questions or perspectives? I'd almost like to segue back to what you were talking about at the end, Sue, particularly given some of the media reports, and I mentioned this as a board yesterday, and the way banter, people can regard things as banter, and you know, it's just a joke. And when anyone says anything which another person perceives as being hurtful or spiteful, it's not banter. None of us have the right to make another individual at work, or frankly in any context, but particularly at work, feel embarrassed, awkward, isolated, lonely, or in any sense fearful. So I would really encourage, and I'm really encouraged by the level of speaking up, as you were talking about in terms of different colleagues. For colleagues to speak up if other colleagues are doing that. One of the very clear bits of feedback I've had, particularly from BAME colleagues, is how disappointed and isolated they feel when other colleagues hear a racist comment or a homophobic comment, and their colleagues don't say anything. They don't speak up to support their colleague. And we all have, you know, life's a moral journey. Life's about standing up for what's right and to call out things that are wrong. And in behaviours in particular, a bedrock of our success as a trust is the way we behave towards one another. And we need to make sure our standards are high and we stick to that standard and we don't dilute that standard. So Sue, the work you do in all aspects of that work is very important. So thank you. Have a Merry Christmas. Have a mince pie on us. Take care. Look forward to seeing you soon. Okay, team, we'll move on then to the Digital Health Board and EPR governance report. Sophie, what would you care to pull out of this?
Just wanted to pull out, it was in the last report and I didn't mention it, just around the site office and the move to digital screens rather than a whiteboard, and the transformation that is for that team, and that's really pushing the boundaries for us, leading the way with some of that digital work. In terms of some things on our radar, there's some work ongoing at the moment that Harkinar's leading with Innovate around prioritising our digital work to make sure we can't do everything, particularly with the EPR coming, but making sure what we are focusing on are things that really support and move forward our strategy. So that piece of work and getting everyone's views on that will help form a real focused piece of work around digital for the organisation. And then finally, it mentions the readiness proposal. In terms of that, are we ready to go in the first gateway? We had a dry run of that this week, that went really well. So expecting the first gateway actually to be okay. There's still some things for us to do around recruitment, but it's definitely heading in the right direction. There was a positive feeling about that first gateway.
Thank you, Sophie. Questions and perspectives on this report, Glenn?
Yeah, you're right to pull out praise for the IT team on the digitisation of the site office. I mean, there's a lot of organisations across the NHS paying a small fortune for electronic bed management systems at the moment, and for that to be delivered in-house and to see how good it is, it's really impressive. And I know that the Worcestershire Acute team are coming over to take a look at it as well to see if they could adopt it.
And Sue Whelan-Tracy making her presence felt in the last board with us. Sue?
Yes, briefly. I really like this report, and I wondered if after each of the initiatives there could be a sense of scale in terms of how many patients it supports, how many staff it supports, because some of them are really, you know, big and make a really big difference. And I just think that sometimes when I read it like this, I can't really see what it means for patients and staff. So just a little icon with a number on it of some sort.
No, great point. Thank you, Sue. And any other points? Sophie, I still remain very significantly unassured and therefore worried about the UHCW EPR deployment and us making sure that we don't in any measure replicate their experience. I'm surprised by the statement which reads, there have been no major technical issues reported since go live. So I'm still very perplexed as to why UHCW has had such very significant implementation problems in terms of keeping its elective capacity running. And they're still, I think, negative year on year. So for the next report, can we beef out the UHCW bit? But also, if there have been no technical issues since launch, what on earth are the issues? Are they purely around implementation, training, process change? In which case, help to provide us with assurance that we will not replicate their experience. Because until launch date, and their launch had already been delayed, I think 6 months since its original date, they'd been assuring us that they were absolutely on it in terms of pre-implementation training. Sophie?
Yeah, I agree. And just to say, at the group board, we're going to do that focus session. So we'll hear a bit from partners in the group, but also another organisation that's deployed the same system, but not had necessarily the same issues. I know Bascar's had conversations with them. So we'll bring all that together and then we'll make sure we pull that through into the SWFT board.
Tip top, thank you. Okay, team, we'll move on then to the report from the Council of Governors meetings held on the 1st of October and the 14th of November, which I will take as read. But I do want to, as I know some governors, it's a re-election cycle, so I want to thank those governors who are standing again for re-election. But also, and I will do this more formally once I'm clear as to who definitely isn't standing, but I do want to thank those governors who have decided not to stand again. It is a very demanding role, but a very important role in terms of our governance. But any questions from the board on what is written from those two meetings? Okay, thank you. So I'll move on to the Audit Committee report from the 14th of October. Robert, anything you'd like to add to this?
Yeah, just a couple brief highlights, Chair. I met with some of the other audit committee chairs within the ICB boundary. That's a useful start to some discussions about how we can better understand the risks in the system, both at an individual organizational level and cross system. So we'll continue those conversations. We did some follow-up work on a report that identified some areas we need to improve on under data quality and the diagnostic activities. So we'll keep that going. And then we've got some successfully completed its evaluation of the external, and we'll be discussing that at our meeting next week.
Okay, thanks, Robert. You broke up a little bit there, at least ways on my system. But any questions to Robert? Okay, thank you, Robert. Great to have you on board. It feels as though you've been with us far longer than the 6 months you have. Clinical Governance Committee. David Spraggett, anything you want to pull out of this report?
The only thing I want to sort of pull out particularly is that there's been a number of reports that mainly from community teams of an increase in what's principally verbal aggression, but occasionally it has been physical aggression towards them. And it's a particular concern because many of those are lone workers. And interestingly, it's not necessarily the patient that is aggressive, it is sometimes the relatives of the patients. And I think that makes it extremely difficult for our staff to deal with, because they still have a responsibility to deal with the patient regardless. And I think it's that some of these do tie in, because one of the things I did report is there's some retention issues in community palliative care, and those are the particular situations they're having real difficulty with. So I think anything that we can do as a board to support them, we should do. I know there's been an agreement to supply lone worker devices, which should give some confidence, but in the end, what we need is to get a message out to the public that this is unacceptable behaviour. And I'm not quite sure how to do that, but I think it's something we need to emphasise.
No, absolutely. And I think going back to our paediatric community team earlier, that's definitely one of the issues they've had. I would say to members of the public who are listening in, we're here to help you. We will do so with kindness and empathy and understanding. But you do have, all of us have, the responsibilities as citizens and users of the NHS to treat staff, whether it's in the ED, whether it's within the hospital, or whether it's within the community, with equal respect and kindness and civility. Thank you, David. We'll move on then to the strategic direction bit of our report and the progress report on annual trust and foundation group objectives. Glenn.
Yeah, thank you, Russell. I talked through this report actually at the last Council of Governors meeting, because it's a report that we share with governors, because obviously the objectives are co-produced with governors, and they cover a whole range of initiatives across the organisation. As you can see, we also brag rate them, and generally we've got some mainly greens in there and some things on amber. This was a mid-year report actually, so doing pretty well in terms of progress. Obviously there's still time to get them all green. One area that I wanted to emphasize that we do need to do some more work on is under the Home First area, number 4, which is about how we take on the community integrator responsibilities as an organisation, and the lead provider role that comes with that. It brings to the organisation some very important services that we need to ensure that we manage effectively for the benefit of local communities, and that we also work as lead provider, but in collaboration with partners in the system. So it's one that we'll be spending a bit more time on, and something that I'm sure we'll talk to the board about in terms of how we strengthen the leadership arrangements in the trust in order to deliver that. But otherwise, some good progress in a number of areas.
Thank you, Glenn. Questions and perspectives to Glenn? Yeah, Glenn, I just want to segue back to the point you made there about the integration and our role as lead provider. As we are part of the system, every year, every 2 years, we do a point prevalence study which shows the savings that could be made for the taxpayer if patients were being given the healthcare they need in the right setting. That regularly shows there's about 10 to 15 million to be saved. Us being in that lead provider role and the lead integrator role allows us to start to capture some of that. And when we look at the financial situation that the whole of the UK is in, and the NHS in particular, as Glenn has indicated, us accelerating towards that transformational role and implementing it is going to be absolutely the key to ensuring that not only is healthcare delivered in the right setting, but that healthcare is affordable, because we are facing an awful lot of financial headwinds at the moment. So Glenn, you have my full support and the whole board's support on that. Okay, we'll move on then to the summary of ratified policies, and there's a new bereavement policy. Sophie, anything you want to add?
No, it's just here for information.
Okay, thank you. So we will duly note that, and then we're on to the Security Standards 6-month report. Harkamel? I can't hear Harkamel. Can anyone hear Harkamel?
No.
I tell you, she needs to put 50p in the meter. And
I'll pop down to her.
Okay, so we'll come back to Harkamel. Thank you. We'll move on then to the Health and Wellbeing 6 monthly report. And Sarah, anything you would like to pull out of this report?
No, I mean, I'll take the report as read. You will notice that the format of the report has changed. We appointed a new health and wellbeing business partner working across SWFT and George Elliott, who started in the summer. So he's taken the opportunity to do a bit of kind of a baseline review of all the interventions that we have, with a view to us taking more of a kind of data-driven and evidence-based approach to identifying what are the most effective wellbeing offers. That also links in with the research study that we are undertaking or is being undertaken by University of Warwick. So moving forward, we will have kind of a more measurable way of monitoring the effectiveness of our health and wellbeing interventions. But I'm happy to take any questions.
Thank you very much, Sarah. Any questions to Sarah? Ollie Hisco's just popped into the chat box commending Sam and James and the Health and Wellbeing team. Thank you for doing that. And like we said, please thank Nick for his leadership over the last few months. We'll move on then to the update Register of Directors and Register of Directors' interests. Sarah?
Sorry, Harkamel and I are just swapping seats. So happy to take it as read. It updates both of the registered with the recent changes to the acting arrangement and other changes that I've been informed of. So it's for the board to receive and note. Thank you.
Okay. Any questions to Sarah on the accuracy of those? So have you got Harkamel next to you? Okay. Buy one chair, get two directors.
No, sorry.
That's okay. Well, not the end of the world. So we were talking about the Security Standard 6 monthly report, which we'll go back to. What would you care to pull out of this?
Well, it was just to say, basically, my update is the same as David's, and to provide assurance to the board that we are linking in with the clinical governance findings. So you'll see that the incidents of violence and aggression reported have gone up. We have done a lot of work to try and encourage people, but actually the severity and seriousness of some of the reports really do warrant further action. Kim did put in the chat about the lone worker devices that we've purchased. So we've purchased 1,450 and they are being rolled out. And the other thing I wanted to just pull out was that our overall compliance against the standards has improved. So for the first time, we are actually green overall. And I just wanted to highlight that, partly to thank Fiona Dwyer, because she has worked tirelessly to make those improvements, but also to provide assurance to our staff that we do take this very seriously. We've got a number of action plans in place, and we will continue to work to improve safety and security at SWFT. It is really important that people do come forward. So if there are incidents or anything that people haven't reported and they want to talk about, like in further detail, any one of the board are open to that conversation.
No, absolutely. Thank you, Harkamel. And it is deeply concerning that members of the staff are assaulted by members of the public. Any questions or perspectives to Harkamel? Harkamel, if we can arrange for me to do a visit with the security team, I'd just like to understand a bit more the challenges they face, given that the level of incidents are going up. That would be great. Thank you. And so we move on then to board committee minutes. The first is the audit committee of the 11th of September. Robert, anything you'd want to add to these?
Nothing, Chair. There. Take it as read.
Okay, any questions to Robert on those minutes? Okay, can't see a hand raised. So we'll move on then to the Clinical Governance Committee of the 11th of September and the 9th of October. Anything you want to pull out, David?
No, nothing to add.
Okay, thank you. Any questions to David on those? So I think we are then on to any other business. Any other business? Board colleagues, please raise a digital hand. Okay, just a couple of things from me. The first is a shout out. I mentioned Adam earlier, but also a shout out to Fiona Burton, who's on sick leave at the moment. Fiona, if you're watching, we wish you well. Ellie's doing a great job for you, but we all miss you. Ellie probably more than all of us. So get well soon. The second is, I mentioned at the start of the meeting, this is the last board for Simon Page and Sue Whelan-Tracy, who have worked with us here for 9 years at the start of next year. Simon has been my vice chair for a number of years, and Sue Whelan-Tracy has been the senior independent director. I could have not asked for more professional, supportive, challenging, in a very appropriate way, non-executive directors. You've been absolutely fantastic, and I wish you well for future careers. Thank you very much. Sarah, do we have any questions which have been given from members of the public?
No, none submitted.
Okay, we're running a few minutes early, so if any members of the public want to ask a question, we'll do our best to answer, but please raise a digital hand. Okay, I can't see any digital hands being raised. So I'll draw the meeting to a close. Wish everyone a very, very happy Christmas. We will adjourn for the confidential board and get back together again in 10 minutes in the confidential board. In the meantime, Merry Christmas, everyone. Take care and enjoy a mince pie on me. Thank you very much. Bye.
Bye. Bye-bye.